First, this is my outline of this brief presentation. So just very few slides on virology, because in order to perceive what is happening in the laboratory as well as how to interpret. And since the topic is my specific topic is laboratory diagnosis, under these headings, why we want to have a laboratory confirmation, and what to take, that is the specimen, and whom should we actually obtain specimen, especially in a context of an outbreak, and when to take the sample, the ideal or the best, and of course how to take it, and how to transport it, and if there is a delay, how do you store it, and special mention about viral transport medium. And of course moving to laboratory, the test, and with some special emphasis on turnaround times and current situation and current data. Because of the time limitations, I didn't prepare previous slides, but we can actually discuss. So virology is also mixed virus. It's an embryo. The significant feature is the segmented one. And of course, as you all know, there are hemagglutinin and neuraminidase. It should be actually 18, because recently there are 2 bad viruses. So there are actually 4 types of influenza virus. Why? Because there is a type called D, which was diagnosed in 2014. But as far as human virus are concerned, it is not as significant. But since there are biological trainees and of course microbiological trainees, I just want to share this new discovery. So, but we are going to pay more attention on influenza A, as I mentioned previously, 18 subtypes of hemagglutinin. This particular hemagglutinin glycoprotein is important when we are actually talking about, especially in the laboratory context as well as research, and when it comes to vaccines as well. So there is another nomenclature as well as an important enzyme called neuraminidase enzyme. So influenza A, we actually, just like our first name as well as our surname, we have this nomenclature of having what is the particular H1 subtype and what is the neuraminidase subtype. So we can have under the sun there are 50 odd combinations, but as far as our humans are concerned, especially clinically concerned, not animal surveillance or not research, 3 subtypes are more prevalent, and especially in laboratory diagnosis also we talk about these things. So just why laboratory diagnosis is important, and before that I just want to mention that I'm mainly concentrating on laboratory diagnosis in clinical aspects, because our main audience as well as our agenda is like that, but when and where laboratory diagnosis is important in other aspects, we will just mention. So just to mention what's happening in the virology of influenza, you all know this is the third MB part, that is endogenic drift and endogenic shift. So this is just to complete the picture only. A minor drift that is acquiring in a human is having endogenic drift. But as very recently, that is in 2009, what happened is that endogenic shift, where influenza, when acquired by, especially by other animals and with close contact with humans, it can undergo major change that is called endogenic shift. So there is a new strain. Papa Madam actually mentioned this, but I just want to emphasize that this is an acute infection. So this is not like a chronic infection, or in fact something like 2 or 1 or more 2 weeks. It won't go like that unless you are immunocompromised. And of course there is clinical definition as well as some case definitions which we actually take for our influenza surveillance. Fever is one of the cardinal signs, but not only, because 10% of even normal healthy individuals can present without fever. So type of pharyngitis, laryngitis and tracheobronchitis. In children, of course, this is actually was noted in 2009 in several parts of the world, even in the backdrop of a pandemic. The children, 5 to 7% of children can present with diarrhea and vomiting without respiratory symptoms. There have been outbreaks, especially in Latin American countries, where diagnosis is not optimal. So one can have long convalescence, but usually it's 1 week. And more important thing is pneumonia. That is, of course, we are having that now at the moment with this maternal and of course in risk factors. And outbreaks do occur, especially in our part of the world. We don't have a particular clear-cut seasonal pattern as such, with the seasons just like the temperate climates. So we do have outbreaks irregularly. So no one can actually precisely predict, but that is the one that we are trying to address by means of surveillance. So special high-risk groups, because when we come to my specific topic, we need to know in an outbreak setup whom should we actually prioritize in the event of a logistic and reagents limitation. So this is the list. This is not the complete one, but more towards with age group, with medical conditions, those who are having. This is actually a Western type of thing, because we don't have actually institutions, very large institutions with elderly and other care. And of course, this is also important where there are, for instance, adenovirus is known to cause in army recruits and in dormitories. Similarly, influenza is also sometimes, not sometimes, it causes in these closed communities as well, so it should be included. So coming to the proper diagnosis, why 1 to 8? This is the proper presentation. So why do you want to diagnose it? Because it's not now, for instance, fever, cough and cold and other, of course, lower upper respiratory tract infection in that matter, lower as well. It's a common thing. But you can make a clinical diagnosis, especially with the clinical and epidemiological picture. But speaking in context of this current scenario, in certain individuals and in atypical presentation, for instance, we had, especially my memory always go to 2013 MERS epidemic, where we had 1,800 cases with, of course, unfortunately something like nearly 29 days with 6 maternal deaths. So there were atypical presentations as well. Patient was there for quite some time. Of course, cough is there, but not fever. So assault was started. So we need some, especially in risk factor group and atypical presentation, we need to have a laboratory confirmation. And if therapy will benefit, these are actually ISDA guidelines, American Society of, and there are American Society of Infectious Diseases guidelines. And of course, when it comes to not only an outbreak, but in normal non-outbreak situations also, the type can be sometimes, and especially in an early of the disease, we are trying to do more than 10% to know what kind of a type and what kind of a subtype that is currently circulating. And these three, the why there's a gap, because these three are more clinically oriented. But laboratory diagnosis, especially in our institution, our center, Influenza, the Department of Biology, is not per se for the individual patient as well, because it goes beyond that. That is, the characterizing the virus, what kind of a virus, by doing hemagglutination, whether it's actually some typing with the previous antiserum that is sent by the WHO Collaboration Center, and of course we do try to solve culturing viruses, and of course antivirus sensitivity with the collaboration of our higher collaborative center. So this is the one of the important slides in my listing, that is quality sample. Accurate result is accurate report. What goes in, what goes out. This is the fundamental thing, but unfortunately, most of our clinical or the boards does not understand this language, because we are not magicians. We cannot convert a poor quality sample, whatever like relationship the patient is having with the administrator or the political thing, we cannot convert into a good sample. So before that, uncomplicated influenza, just to have this, what is happening, and when we want to take with the sore throat, myalgia and cough, incubation period, and with the fever, because in the surveillance we take fever as a clinical sign. So this, I don't know whether, fortunately this resolution is very good, because the previous it was not. So there are several types. There are type of specimen, that is nasopharyngeal wash, throat gargle, that is throat wash, and nasopharyngeal swab, and oropharyngeal swab. This of course is another slide taken from a journal, but we always discourage this nasal throat swab. I always tell my trainees, don't ever use them, because it actually have a misnomer, because we need to have a nasopharynx. We need to go to the nasopharynx and the oropharynx. The next slide will explain to you. Before that, of course, the virus is treated with the day, and of course the antibody increasingly with the antibody. Sorry, this is the one. Yeah. Because this is of course saliva, and of course with the other things. So we need to have oropharynx, and of course in the nasopharynx. Right? Nasopharynx. So respiratory specimens in order of frequency of importance, especially uncomplicated with fever. So nasopharyngeal swab we prefer, but of course nasopharyngeal aspirate in a certain context, especially in ICU setup, we would prefer. Then of course the oropharyngeal swab, and of course going according to the anatomical side, tracheal aspirate, bronchoalveolar lavage, lung biopsy, and paramortem trunk science if the available facilities are there, true cut biopsy or an autopsy sample. Not blood, because the previous slide, that is because we do get, even in the context of 10 years of surveillance with lot of education, we do get blood for H1N1, that is the coding there. So we cannot come to an acute diagnosis with serum. So this is we are using a high flexible swab with nylon flap, where actually secretions are absorbed, and it's a score. This is actually commercially bought through the epidemiology unit, CDC funds. And of course nasopharyngeal aspirate, because in certain situations, and not exclusive to influenza, but especially RSV, especially in children, we prefer a nasopharyngeal aspirate. So in order to obtain that, there is actually a trapper, mucus trapper, transporter, both it suits the purpose. And of course we have to extend the neck, and you have to, before sucking, you have to quickly insert it, and then of course switch on the sucking and suck the secretions. And when the secretions is trapped, you actually remove the thing and suck viral transport medium. I'm sorry, here it is clear, but during the transition it is not there. So you have to remove this particular component after sucking the viral transport medium. Whatever trapped inside these tubes is sucked. So this is the mucus trapper plus transport or two purposes in one tube. So this is again in an adult where you have to extend the neck. So you need to have this checklist. So you need to properly secure it, no leakages. We have a special request form, because what we find is it's not a PCR positive or negative. It's going beyond that, because especially my trainees know in the afternoon we go through each and every request form and try to interpret it, and there's an interpretation sentences as well. So we need this request form. We always encourage to fill this request form and accompany them. So there is a collection guide as well. It is in the internet. Overleaf of the request form, we have developed this detailed guideline. It is available in the web. So we have to fill the data, and also you need not. This is not a compulsory thing, but to be on the safe side, the request form should not accompany inside the container. So this is surveillance site transportation, but we always encourage to transport at 4 degrees. So real-time PCR on home in an event of outbreak. That is not on all suspected patients, because the high cost, not only the cost, because of the logistics. And at this moment also we actually screen whatever the sample is actually coming to MRI on having high risk factors, and depending of course on the circumstances as well. So we recommend to authorization from the clinician, but ICU setup or given time, of course, medical officer or senior registrar or registrar, whoever can actually request the test. So there's a guideline, 2013 guideline, we are following that guidelines in an outbreak situation, admitted patients only, with detailed clinical history, with investigation, and we are compelled to screen, because this particular given moment also there are 40 odd samples in the department where usually 10 to 15 only a day in an outbreak situation. So in the event of a delay of transporting, this is you should not freeze at all, because at the freezing influenza viruses die. We are not stopping at the PCR level. We always try to culture it for further characterization. So if there's a delay, we need to store at minus 70, and during the transport we need to keep it cool. So this is the viral transport medium, commercial medium, again bought through the CDC funds and of course local purchase as well. Previously we had this Buju bottle where we need to keep it at 4 to 8. Here of course we can keep it at room temperature, but we always encourage, because of the room temperature sometimes goes in certain areas 30 to 32. So we always encourage to keep it before use at the refrigerator. So what are the common faults? This is the next important slide. Leaking samples, request for soak and wait, not transporting lines, ice melted once inserted, many plastic wrapped around, no history in the request form. This is so much so that sometimes in other areas of our department, the main obstacle of interpreting and request coding, this is a very cumbersome thing, because we do not have insight to other people's mind or other people's requests. So short forms, THK, it stands for so many things, we can't post the report. So the next one is the laboratory test. So direct antigen test, we have used it, but now at the moment we have discontinued it, and molecular technique, which is the main aim, and isolation of viruses. So this is how it looks like under the immunofluorescence microscope, and this is a clinical sample, and this is on-site unisolated. So we do culture, we try to culture on a selected basis of positives. So this is again a laboratory diagnosis of test that is in the influenza. So these are the turnaround times, usual turnaround times in a non-outbreak situation. So just to give you what are the samples, and this is again the real-time PCR is the one that is the mainstay. So any sample can be actually obtained on this, any respiratory samples. And of course viral culture, this is not for clinical diagnosis, but as the National Influenza Center, we are compelled to have the terms of reference. Rapid diagnosis, there are two slides, because in an event of outbreak, and as well as WHO position paper, sometimes endorse sometimes, only in certain situation, outbreak situation, we can use immunochromatographic test. So this is just, there are several models, not at a higher level of a laboratory, but certain institutions at the point of care test. So their sensitivity is very variable, not optimal, but specificity is high, especially in an event of a given outbreak or the positive predictivity in a peak activity or community outbreak. You can use at the first time. Then of course if it is negative, you have to confirm it by PCR. So this is the most commonly asked, frequently asked question. How soon we can get the report by sending? So there are so many factors, that is our factors. First of all, PCR is not the full blood count or a blood picture. It takes processing, it takes allocating, so there are so many steps. Just want to say, because we are expecting our clinical colleagues to be here. So it takes, the whole process takes 6 to 7 hours. It's the whole process. It happens in so many rooms, that's why it takes. So we are following the quality control procedures. Each test is actually having a lot of controls, because we need to be absolutely sure that if the result is there, and we follow each year Hong Kong having external quality assurance panel, and we do send our representative sample to our higher center. So laboratory diagnosis, this is sort of a summary, very expensive, not only for indicated patients, not on all, especially in outbreak. We need to have the correct sample, correct storage, transport, and proper history. So just the final 4 slides, I have taken a little bit 2 minutes behind my scheduled time. So this is 2015, right? 2015, as you can see, we actually noted this in end of May, where Hambantota had several cases, but because of the outdoors, single outdoor season, I think it has been. So at the moment is 33%, and current strain is H1N1. It was H3 into 2014, as you can see here, but now of course it's 2015 in 2000 H1N1. So how I'm going to show this slide is H1N1 and transmission. So this is the latest ending yesterday 5 p.m. 31, 19, 2. So it's influenza A. And these are the last 5 years. So as you can see, there are two peaks. December 2010, 2014, 2012. These are the other. Then of course the other peak. At the moment we are here with 33%. Where of course December there was 32 or 28%. The moment we are here, so it might go up in the next few weeks. So we are disseminating our data, we are posting it to our website, and I'm emailing 102 stakeholders of Influenza, and we are actually every Thursday we are updating our global Influenza website. So in summary, proper collection and transport is essential, and we need support of ward staff, clinical staff, and even sometimes the OPD staff in order to make this effort a success. And risk groups only we are actually offering or trying to diagnose, but it is not strictly as we can always have with the clinical material. So PCR is the mainstay, and we do disseminate knowledge. And current outbreak is the main strain is influenza A H1N1. Of course, I would like to thank our group. I'm just only the leader, but our small team is really working hard. And we are here because of the previous our staff, Dr. Vikramasinghe, and as well as our MLTs, orderlies, and others. And we have very good collaboration with Epidemic, AVI Basicum, WHO countries, and our offshore collaborators as well. Thank you very much. I apologize for that not keeping